Hello, my name is Dr. Faisal Anwar. Today we will discuss another case of cataract surgery. This is a mature cataract with small pupil. Pupil is not dilating and the AC is shallow. So first of all, we will try if we can dilate the pupil. You can see the iris is floppy. So we will stain the anterior capsule with the trypan blue dye. Now we will wash the dye from the anterior chamber. After washing the dye from the anterior chamber, we will inject intracameral adrenaline to achieve dilatation. Here you can see we still do not have adequate dilatation, so we will now try the viscoelastic. Now after using the viscoelastic, this is the maximum dilatation we can achieve, and this is temporary dilatation. So we will try to do capsular access. When we started the capsular access, we noted there is anterior capsular fibrosis or opacification. You can see central part of the capsule is fibrosed. So what we will do, we will along the margin of the pupil, we will give nicks so we can achieve small rhexis of the size of the pupil. As anterior part is fibrous, you can see now we can see the little bit of elastic capsule that is near the margin. By using that elastic capsule that is possible to move, we'll do some rhexis. Always remember, if you do a small rhexis, we can make it big, but if you do a big rhexis, we cannot make it small in hypermature cases. So here we are trying to avoid the central fibrotic area and keep completing the capsular rhexis. Now you can see we have removed the central fibrous. You can see the white part in the in the anterior capsular flap. So somewhat we have achieved the capsular rhexis. Now we will not dial the nucleus as we do not know the status of the capsule posteriorly. Now that the tip in this case is do your phaco power up to 75%, 70 to 75%, and start on the third step, that is phaco. Do not try to aspirate the epinucleus. Start directly on third step and make a pit in the center to weaken the nucleus or the cataract. You can see here I am trying to remove the central nuclear material by using the phacoemulsification power that I kept around 70 to 75%. Now you can see after doing so, I still could not get adequate dilatation of the pupil and the depth of the AC. Now deep AC is very important for the capsule, for the phacoemulsification. Now after giving a one crack, I am trying to dilate. So if any synechies are present posterior to the iris with the bag or the nucleus, that gets weakened and we can get dilatation. Again, the dilatation process is not that comfortable, so we decided in this case to again weaken the nucleus. Again, after weakening the nucleus, I noted that again I am giving the cracks. I kept on giving the cracks in the nuclear part, or kept on chopping it, but what I felt was the nucleus was adherent, or you can say the cataract was adherent with some areas of the bag. After noting it, maybe in the equatorial region, you can see by removing the iris or displacing the iris with the help of the dialer, I saw some areas that I felt are not good to dial the nucleus. So again I am trying to make some pieces. So there is a blood, sort of a blood part, blood image, and the patient is moving the neck also. So again, after making multiple chops, usually I do not use any other accessories or supportive components to remove. Normally hypermature cataracts can be removed with the small pupil, from the small pupil, but in this case the capsule was adherent with the nuclear fragment, so I kept on irrigating it or kept on breaking it into central. You can see I'm not going to periphery, I'm cracking it in the center only. You can see, so somehow I displaced one of the nuclear fragments. You can see here, so that nuclear fragment I am removing. Again I noted that the pupil is more sort of getting smaller and smaller, and the AC is getting shallower. So I decided not to continue and use some support for the dilatation of the pupil. Again, first support that we can use for the dilatation of the pupil is adrenaline. Second support is gel or viscoelastic, and the third support is iris hooks. So these are the three supports that we use for the dilatation of the pupil without damaging the pupillary sphincter. So after using dialer again and again, then using gel again and again, I am trying to remove some of the central nuclear material. Here you can see I cannot go to the periphery. What I have to do is mainly in the center. My target was to make central nuclear pieces as much possible. So if we have to remove it, we can remove it easily. So you can see again we have removed some of the nuclear components. Again kept on chopping it into smaller pieces. Again AC is not getting deep. There is peripheral discoloration of the iris, indicating there may be some. So there is peripheral discoloration of the iris, that indicates the iris is weak or floppy. So I pushed the nuclear component back with the help of the viscoelastic and again dislodged the nuclear material. So I am retracting the iris to break any synex present posteriorly. Now I again put in the gel and pushed the pupil back. Now I decided to use iris hooks to conclude the case. As pupil getting smaller and smaller, so I will use iris hooks to open up the pupil and to complete the dilatation, to achieve dilatation and to complete the case. So I will tell you how to use iris hooks mainly in this case, how to apply them and how to remove them. So you can see there is a hook present in front of the blue area, blue stick, and that is like a hook. So there is a small sort of a rubber elastic tire that is present posteriorly. Now this tire is mobile on this thread like material, so we will pull the hook, pull the iris with the hook and make this tire near to the limbus, and it will automatically gets lock. Now again I will make a small entry port with the help of 15-degree knife, and you can see again the hook is going in. When the hook is in, hold from the last component and guide it by left and right or to and fro movements. You can see this tire can go backwards here like this. Now push it forward, engage the iris, and again this is the tire that is displaced forward to lock it. So these are the two hooks. Mainly 5 to 6 iris hooks are present in one packet. So in this case we cannot achieve a square, as I have made two ports in the superior area, so I will not prefer to disturb them. So again I am using the third one. In this case I will achieve half pentagon, like I will tell you in the end. So first of all I will make a rectangle. Now this is the third hook. You can see again I moved it forward, engaged the iris and displaced the tire towards the limbus so I can lock it. Now the problem in this iris hooks is you mistakenly engage the anterior capsule when you are applying it. So once you have engaged the anterior capsule, it can tear the capsule. So be careful while applying it. Only apply it to the iris, not the anterior capsule. Now we have placed 3 iris hooks. Now the fourth one. When we use these iris hooks before the start of the case, we can achieve a square shaped opening with the 4 iris hooks. In this case I am using it in between the case, so I cannot achieve a good square, you can say. So I will try to achieve a rectangle first, that I used to do whenever required. You can see here I have achieved the rectangle like this. You can see I am engaging the anterior capsule, so I am going towards the one that hook is applied on the iris and now guided it to superiorly. Now I am locking it. Yes. So this is the rectangle again. It is adequate to do a phaco, but it is not ideal. So I will use my 5th iris hook. You can see superior ports are safe, so I will use my 5th iris hook to achieve a pentagon type shape. You can say this is a pentagon. Now this is the first one. Oh, this is the 5th one. Now you can say again the hook is how hook will go in. Now the hole to hold this hook, the trick is to use 2 forceps. You can say once you are in, you will guide this tire backwards to increase the area or length. Now you have engaged the iris with the hook, pull it back and now guide this tire towards the limbus, and then you got now you get lock with this hook. Now you can see this is adequate view that is visible to me. Now I will take my phaco in and remove these fragments that I chopped during the start of the case. Now you can see I can easily remove these cases. Now you can see I am easily removing these all cases. Now this is very easy to remove all these cases pieces one by one. You can see all are chopped and we will kept on removing them one by one. Now AC is deep, we have adequate space, all the pieces will keep on coming into the phaco tip, and by emulsifying and aspirating these pieces we will remove them one by one. These are 2. Now you can see due to some technical error we have lost small portion of this video. So now this is the picture after removing it. Now we will inject the lens into the chamber. You can see the lens is going in. We can see the lens going into the bag. Yeah, here it is. Now you can see the lens is on the anterior capsule. Now I will guide this lens into the bag. Here this is in, and this is the second portion of the lens. Now the whole of the lens is into the bag. You can see the small axis that is visible. So we have done with this case successfully. Now we will remove these 5. Now again hold at the periphery, move the tire backwards, disengage and quickly remove it. Now the trick is, don't pull it back slowly. When you are near the edge of the port, pull it back quickly. Now you can see again we are sliding the tire backwards. Again we are disengaging it and we are moving it by. Now quickly removed. This is sort of elastic hook. It gets, when we will remove it slowly, it can damage the port, sharp ports. Now you can see here, I learned this, that by removing it quickly is better to remove it slowly. You can see it gets straight. When you remove it from the hook, it gets straight. So this is the last iris hook that we are removing. Again, yes, it's gone. So you can see the beautifully the lens is centered. We have saved the pupillary sphincter. Now we will remove the viscoelastic and we will see the very stable anterior chamber. We will clean the gel from the areas. You can see the peripheral discolored iris, that was not allowing it to dilate. Atrophic iris at the periphery. Also the iris is floppy as it is coming into the wounds. So we have to look into all these aspects. So now the gel is completely removed. Now we will use irrigating solution into the syringe to wash the anterior chamber. As we will keep on moving the gel, you can see the pupil will keep on coming back. So now you can see here the pupil is very much back as the gel is removed from the posterior as well as anterior chambers. So you can see in such cases, when we have a mature cataract with non-dilating pupil, we always try first to do phaco without using iris hooks. Sometime it happens, sometime we need to apply iris hooks to achieve adequate dilatation to successfully, so we can successfully perform the phacoemulsification. So you can see the end result is very good. We are removing all the gel from the anterior chamber and the pupil is small, so we don't want the gel to be trapped in the posterior chamber. Now we will removing the blood clots that are present around the ports. Here we am removing the ports gel that sometimes gets stuck near the ports, any small lens fibers. Now after removing these all, my habit is to put 0.1 intracameral moxifloxacin also. First I will hydrate the ports. So the ports are hydrated. Now this washing of the anterior chamber is to remove all the gel. Now I will put some moxifloxacin. These small bubbles are present. I have to remove these bubbles. So the case is concluded. Thank you.